So we're moving on to a new topic, still under this concept of cellular regulation, but we're going to talk about cellular dysregulation in terms of lung cancer. Again, just a little bit of cellular regulation review, the concepts of what is going wrong with regulation when we talk about our lung cancer. The abnormal cell growth and the characteristics that are observable in cancer cells. And this is going to be important when we start talking about treatments. So lung cancer. Statistically speaking, it's the most common cancer worldwide. When you look at these numbers compared to the other numbers that we've addressed on other PowerPoints, absolutely a significant increase in numbers. It's the leading cause of cancer death in the US. About 1 in 5 cancer deaths are attributed to lung cancer. Most people diagnosed with lung cancer are 65 years old or older. When we're discussing risk factors, modifiable, non-modifiable. So hands down, bar none, smoking, a history of smoking, and exposure to secondhand smoke are your highest risk factors for lung cancer. There are environmental and occupational exposures, so people who work in construction, for instance, exposure to radon or asbestos, those are relative to certain types of cancer like mesothelioma. Radiation exposure, so people who have had previous radiation, that can be a risk factor for lung cancer. Sedentary lifestyle, having a pre-existing lung disease, so our COPD, emphysema patients due to that chronic inflammation, and then having an infection history like HIV. HIV can actually increase your risk for lung cancer. As far as non-modifiable age, we already discussed that in our statistics. Most lung cancers are discovered in people in the age of 65 or older. Males are more likely than females to have lung cancer. Black males are 12% more likely than white males, but black women are actually 16% less likely than white women. And then having a family history. So that family history plays a role here in lung cancer as well. As we said, tobacco use is the leading cause of lung cancer. Approximately 90% of lung cancers are related to smoking. And there's factors within that. What age have they started? How much do they smoke? Obviously their gender, what product they're smoking, so filtered versus non-filtered, depth of inhalation. So of course we're going to encourage smoking cessation. When we're talking about manifestations, obviously this is a lung disease, so we are looking at respiratory symptoms. So breaking down these symptoms, signs and symptoms into local and systemic. Locally, we might have chronic cough, hemoptysis, which is that blood in your sputum. Patients might have a dull localized chest pain that gets worse with deep breathing, orthopnea, which is that shortness of breath laying down, or dyspnea, that trouble breathing. They may experience hoarseness, so chronic hoarseness, and recurrent respiratory infections that don't get better. Those are some localized in that respiratory system signs of lung cancer. Systemically, that unexplained weight loss, again, cancer is highly metabolic. They may have fevers related to latent infections, anorexia, so that loss of appetite, and malaise, that general feeling of unwellness or fatigue. There are two main types of cancer. There's non-small cell lung cancer, and that has some subcategories you can see listed there. Definitely not going to test you on that information. This accounts for 85% of all lung cancer cases, and fortunately, at that rate, the majority of the cases are slower growing. Small cell lung cancer accounts for about 13% of cases, and you can see there's small cell and combined small cell. This is faster growing and more aggressive. And then less commonly, you'll see things like mesothelioma that we talked about and other rare cancers. When we talk about coming to a diagnosis, we're talking about our usual characters, lab work. So as far as the CBC, we're going to be looking for that bone marrow suppression. And of course, we talked about that symptom of infections that don't go away. So we're looking for infection risk with our white blood cells. We're looking for tumor markers, in this case, the CEA. We've talked about that before in the case of colon cancer, but it's also relevant to lung cancer. So again, looking at what we're seeing going on in the patient, if we have suspicion of lung cancer based on signs and symptoms, and we have an elevated CEA marker, this is going to indicate to us that there is cancer activity and kind of correlate with the symptoms that we're seeing. Pathology we gain from biopsy or fluid collection, and we'll talk a little bit about that more later on. And then these are some of the genetic mutations. So when we talk about genetic mutations within families, those changes in the DNA, these are some of the ones that you'll see. We've talked about this before, but keep in mind, tumor markers indicate that there's cancer in the body, and they're not specific. We correlate them with the signs and symptoms. These genetic mutations are actual changes in the DNA. They're things that can be linked to that family hereditary risk. Our imaging diagnostics, usually chest x-ray is the first step. Often patients come into the hospital, they've had some of those symptoms, that ongoing shortness of breath or dyspnea, chronic cough. They may have hemoptysis and they think they have a lingering cold or flu. And then just incidentally, when we do this chest x-ray to see what's going on, to check for pneumonia, we can find nodules and cancer. Frequently, when you look at smokers, it's often progressed, and you'll see the systemic effects, the fatigue, the anorexia, the weight loss. Okay, that chest x-ray will show the lesion. Lesions usually less than 6 millimeters in size are not considered sufficient for biopsy. So they have ongoing monitors with CT. And I put up these images here so you can kind of see this haziness here. You can see the tumor there in the chest x-ray. CT is a little bit harder to understand, but remember, it's taking cross sections vertically, horizontally, and from front to back. So you get this full image, and you can see kind of those little larger white spots in there. So that's what you're going to see on a CT. As far as diagnostic procedures, we may do sputum collection. So any of these body fluids that we collect here, our tissue samples, we can use to look for cancer, and we do, right? So if we find it in the sputum, we have a concern. Patients can undergo a bronchoscopy, so that's a camera and tool that's inserted down into the bronchi of the lungs. It also allows options for tissue collection, which we can then perform pathology on. If there is pleural effusion, as you can see in this picture here, we may do a thoracentesis, and we will do pathology on that because that indicates that the cancer may be outside the lung now. Okay, and then of course, if there's a tumor that's more in the periphery that we can reach easier, we may do a fine needle biopsy or a lymph node biopsy. As far as cancer management, when we talk about primary prevention, those big things that we're going to look for are radon remediation, which again, that's a smaller portion of the cancers, but then smoking cessation education. That's going to be huge. So we're going to encourage that in our young teenage, young adult populations when most people start smoking. That's the prime time for smoking cessation education. And even in our patients who have been smoking for some time, this is something that we continually reinforce because even ceasing smoking can have profound impact on your risk factors and decreasing your risk for lung cancer. As far as secondary prevention, we're going to be looking at what we call a yearly low-dose CT imaging. This is important. So about after age 50, we'll talk about some of the specific requirements as far as insurance and what we need to do with this in a later slide. But the idea behind this is that after age 50, because we already said 90% of lung cancers are related to smoking. So this is a very, very powerful and effective tool if we can get patients to be doing this annually after the age of 50. So a closer look at low-dose computed tomography. It's low dose, so we're lowering the risk that comes with doing these types of studies that normally have contrast eyes. In this case, no IV contrast eye is needed. Again, it's used for those higher risk patients, so our smokers. It's an annual scan. I will say that there's a debate about effectiveness, and so in what they're talking about when they say that is the idea of whether or not it actually influences mortality. So lung cancer can be very aggressive, as we already discussed. And so that's what the debate about effectiveness is. Not about whether or not it can detect it, but whether or not it impacts ultimate prognosis. Some of the screening guidelines related to low-dose CT, patients 50 to 74 years old and in good health. Again, when we're looking at patients beyond that age of 74, if they're not in good health, what are they really willing to do? What are we really able to do for them in the cancer battle? What can they hold up under as far as the treatments that we're going to require of them? They have to be a current smoker or have quit in the past 15 years. If they have a 20-year smoking history, that's another criteria. Current smokers, they're going to be receiving counseling to quit, which they get every time they come to a hematology office for a visit. The protocol is to just check and see, hey, I'm going to be checking with you every time you come to see whether or not you are moving forward in your journey and ready to move ahead with smoking cessation counseling. They need informed consent because of the risks of low-dose CT. And of course, access is always a question that we have to ask. A lot of patients need transportation. They're not able to get themselves there, or there's not a facility in their area that does this, although, again, this is becoming more widespread, so more accessible. When we talk about tertiary prevention, of course, we're looking at some of the same things we've been looking at all along. Surgery, pharmacology, which includes chemo, immuno, and targeted therapies, and radiation. Surgery involves partial or full resection of the tumor. Most of these tumors, because of where they're located, especially closer to the midline, become inoperable because there's so much anatomy there. So they're only partially resectable. This video-assisted thoracoscopic surgery is one of the options. We can do a thoracotomy, so that's for removal of portions of the lungs. So we can do wedge resections, which are for small tumors, where we go in and we take a portion of the lung and then we suture the lung back together. We can do a lobectomy, which is when we take a single lung lobe. So again, we have an upper and a lower lobe, or an upper, middle, and lower lobe. We can take one of those lobes. And then a pneumonectomy is when we take the entire lung. So it's important to think about what we might expect with lung sounds after surgery. What would you expect to hear? Well, if we're talking about a small tumor and a wedge resection, you're probably not going to hear any difference in the lung sounds. It's basically going to be normal sounds. When we have a lobectomy, obviously we have removed a portion of the lung now. And so depending on where that lobectomy occurred, upper, middle, or lower, we're going to expect that we're going to hear decreased breath sounds in those areas. And then of course with a pneumonectomy, we would expect to basically hear absent sounds on that side of the body. Post-surgically, we're probably going to see chest tube, most likely going to see chest tube placement. So this is where you're going to see these chest tubes in use. This just drains that pleural space after lung surgery. So whether it's a lobectomy or a pneumonectomy, we're going to have that chest tube in place because there's going to be significant fluid there. And we do have infection risk. So this is a closed, what we call a closed system. It drains air and fluid from that pleural space, and it prevents air or fluid from entering into the pleural space, right? We don't want that to happen. We want that remaining lung to be able to function properly. So it's airtight, and that helps restore that negative pressure in the thoracic cavity. So when you think about the breathing process and how negative pressure works in inhalation and exhalation, you really have to go back there in your studies to think about that. But a chest tube helps maintain that negative airspace for that normal functioning of the lung. And so you can see the tube comes out of the side of the body. So it's very important that we're assessing this dressing, right? This is a sterile dressing because we don't want to introduce infection. And it's occlusive, which means it keeps that air from being able to get into that pleural cavity. I've included a video link here. I would take a look at that. It's very interesting. When we talk about pharmacology, again, our usual characters, chemotherapy, immunotherapy, and targeted therapy. These can be used with surgery and or radiation, especially for aggressive types of cancer. We're probably going to get into that targeted therapy more. And we'll explain each of these in the subsequent slides. So when we're talking about um, first-line therapy, we're talking about etoposide and cisplatin. Etoposide, this is an enzyme blocker. So again, when we talk about chemotherapy, it's targeting those fast-growing cells, whether they're good cells or bad cells, right? So we know it's going to cause bone marrow suppression because it's going to attack our red blood cells, white blood cells, and platelets. But we also know that it's attacking those fast-growing cancer cells. And at this point, again, it's attacking them at some point in that cell cycle, okay, to knock out reproduction of the cancer cells. As far as side effects, pretty much the same ones that we expect to see with any chemotherapies that we've talked about. You've got your GI symptoms, nausea, vomiting, constipation, stomatitis. In this case, you may have altered taste or metallic taste. And again, these are patients that we're advising them to use plastic utensils or wooden utensils. You may expect hair loss and then bone marrow suppression. Carboplatin, again, we've talked about this before, but it prevents DNA replication. That's how it works. And the side effects, we have that tinnitus or ototoxicity. So that's one of those concerns that we have to pay attention to, educate the patient on, and be assessing for. It can cause hypokalemia, so these patients may need potassium replacement. It can cause kidney damage, so we're going to be monitoring kidney function, our CMP, or our BUN and creatinine and eGFR. And it may cause peripheral neuropathy. When we're talking about immunotherapy, we're talking about nivolumab, and I believe we've talked about this one before, maybe not, but this is immunotherapy. You see that UMAB, so monoclonal antibody therapy. This binds to and blocks the protein PD-1 on the surface of some cancer cells. This keeps the cancer cells from suppressing the immune system. You remember we said that one of those characteristics of the phenotypes of the cancer cell is that it's able to evade those normal processes of cell replication and cell death. And so in this case, this nivolumab is binding to those PD-1 protein receptors on the surface of cancer cells, and it allows the immune system to attack the cancer cells more effectively. As far as side effects, commonly we might see fatigue and weakness, muscle and joint pain, rash, and then you see that host of GI factors there, nausea, vomiting, diarrhea, constipation. As far as severe, it can cause autoimmune attack. Thyroid is the most common place that it's going to attack, so thyroid monitoring is actually built into the order set for this particular medication. So we monitor that thyroid because it's the most common place that it's going to attack, but it can cause other autoimmune issues that can be more severe. So that's something that we have to watch in patients on nivolumab. And just referring back to the previous slide, it makes sense that we might have that autoimmune targeting when we're ramping up the ability of that autoimmune system. Okay, this targeted therapy, when we talk about targeted therapy, it has a very specific purpose. So in this case, we have this bevacizumab, and you can see that again, it's a monoclonal antibody, but in this case, it's working by preventing that angiogenesis, right? So that ability of the tumor to create its own blood supply. And we talked about this before. So if we're using something that's affecting blood vessels and that circulatory system, it makes sense that we might see nosebleeds or other spontaneous bleeding and potentially heart failure, right? It's affecting our vascular system. We might expect CV effects. Radiation, there's really nothing new to see here. We're going to resort to external beam therapy. This is obviously our most common radiation option. It can be used alone or with surgery and chemotherapy. We already talked about that. It can be curative. So if we do a wedge resection and the small tumor is removed, we can follow that up with radiation to make sure that there's no possible cancer cells in that surrounding tissue margin. It can be for palliative symptom relief, and this is when you're mainly going to see it again because of the nature of lung cancer. So it shrinks the tumor, that's what it does, and then it relieves some of those common issues that occur with lung cancer based on where that lung cancer is located in the chest and interfering with lung function and cardiac function. So we're going to see that it's going to relieve that dyspnea. It may open up the airways a little bit by shrinking that tumor. It may relieve pain and pressure. And then, of course, that superior vena cava syndrome, where it's pressing on some of those large vessels in the head and the neck, It can help improve cardiac output by shrinking the tumor and decreasing its impact on those vessels. And again, you can receive brachytherapy, you can do the internal therapy, but most commonly it's going to be this external beam radiation therapy. When we talk about nursing care for lung cancer patients, we're going to be really focused on that respiratory system. That's where we're going to primarily see our problems. So when we talk about focused assessment for respiratory care, we're talking about listening for abnormal lung sounds, right? We know that there's going to be fluid issues. We know that there may be pressure on the airways and interruption of the patient's ability to bring in or move out air. So we're going to listen to those types of sounds. We're going to look for areas of decreased breath sounds. We're going to look for signs and symptoms of respiratory distress. And if you think back to your 150s when you talked about respiratory disease, we're talking about use of accessory muscles, right? Tripoding, that kind of cantilever, abdominal, chest breathing. We're going to look for increased respiratory rate and heart rate that shows that the patient is working harder to accomplish the same respiration and perfusion. We're going to see decreased O2 saturations. Patients may have cough, and we're looking for signs of cyanosis to show us that the patient had decreased perfusion. So purple in the lips, and decreased cap refills, and low O2 sats. As far as nursing care and our interventions on how we're going to help the patient, supplemental oxygen, so we're going to keep that O2 sat above 90%, and we want to keep the respirations between 12 and 20. If they get above that, we're going to have to resort to additional means for helping the patient breathe. We're going to keep that head of the bed up, so we're going to keep them in that Fowler's position, because that is going to help with their breathing as it does in other respiratory situations. We'll suction as needed, so PRN suction. Bronchodilators. We may give the patient bronchodilators. We know that they help relax the muscles in the airways, and it helps to widen them, so that may allow them to take in more oxygen. And then we're going to make sure that we plan good rest periods into our nursing care, right? We're not going to have these patients expending that energy when they don't have the proper oxygen to support it. As far as lung cancer complications, these are some of the more common complications: metastasis, pleural effusion, and then underneath pleural effusion, you can see I have pneumothorax here. This is actually a complication of thoracentesis, which is our treatment of pleural effusion, and we'll go into that a little bit more. Ascites, which is that abdominal fluid in the abdominal cavity, and then our oncological emergency, which is that SIADH, that symptom of inappropriate diuretic hormone. When we talk about metastasis, we're talking about most commonly into the lymph nodes surrounding the tumor, can be in the brain, the liver, most common place, 40% occurs in the adrenal gland, and then of course in the bones. And so thinking in terms of these sites of metastasis, we may be seeing additional signs and symptoms, right? We might have bone pain, or we might have increased fractures, things that indicate that there's something going on metastatically in the bones. So we learn to look for additional symptoms based on where that metastasis is revealing itself. So pleural effusion, as we talked about before, is that buildup of fluid between the layers of tissue that line the lungs and the chest cavity, right? We have kind of that sac that lines the outside of the lungs and also the chest cavity. Some signs that we might be seeing pleural effusion. We might have decreased or absent breath sounds at where the effusion is, right? Because that fluid in there is going to be preventing the lungs from expanding the way that they should. We already talked about what respiratory distress is. We may see signs of respiratory distress in the patient. That increased respiratory rate, that use of accessory muscles, that decreased oxygen saturation, those are all signs of the respiratory distress, that hypotension. And then we may see tachycardia. And when we see tachycardia, remember when we talked about edema before, we talked about the fact that there's, when that fluid moves into the third space, even though that patient has fluid in their body, they can be dehydrated, right? They can have that hypovolemia because that fluid's being pulled into a space where it's not supposed to be. So it's not being effectively used in the body, in the vessels, and in the cells because it's been pulled into a space where it doesn't belong. So we may see this tachycardia, and that can indicate that the patient is experiencing that hypovolemia. The way that we manage pleural effusions is with thoracentesis. The patient is in hospital. This is typically done down in interventional radiology where they can do imagery to insert the needle. Obviously, we don't want to damage any of the surrounding structures and particularly the lungs. It's a therapeutic thoracentesis. So the goal is to remove that excess fluid and so improve their oxygenation / perfusion, right? Lung cancer, because of the nature of the tumor and the damage that's going on, it can cause recurrent effusions. And so that's going to mean repeated thoracentesis. This can be really discouraging and frustrating for patients, although it is a tremendous relief when that fluid is drawn off. Now, we talked about the patient going down to an interventional radiology. We talked about pneumothorax. This is as a complication of thoracentesis. What pneumothorax is it's a collection of air. So we talked about pleural effusions as that collection of fluid in that pleural space. Now we're talking about air in that pleural space, but that air doesn't belong there. So it has that same impact on the lung, right? It's putting pressure on it or even collapsing it, and the lung can't do its job. So whether it's pleural effusions that are causing this problem or whether it's pneumothorax that's causing this problem, either way, we're going to have those same problems with respiratory distress. So you're going to be assessing kind of those same signs that there's a problem. So again, increased respiratory rate, increased heart rate. If that lung is collapsed or pressured, you have one lung doing the work of two. And so the heart is going to be working harder to get that perfusion, to get that oxygenation to the rest of the body. You may see blood-tinged or frothy mucus, and that's an indication that there's air in that pleural sac. You may have uncontrolled coughing. Again, the body trying to do something to relieve that lack of oxygen on that side. You may have something called subcutaneous emphysema, and what all that is, it's kind of that snap, crackle, pop. I think you probably talked about this in your 150s or 151s, but it's that air underneath the skin so that when you press on the skin, you can actually hear that crackling, that indication that there is a problem there. And then, of course, you're going to see those signs of hypoxemia, like we said, shortness of breath, cyanosis. You may have some neurological symptoms like headache, confusion, and being disoriented. Patients not getting enough oxygen, it's going to impact them. When we talk about nursing care and we're managing that pneumothorax, of course, one of the first things we want to see is that their respiratory status is improved. So post-surgery, post-procedure, so if we do that thoracentesis, we expect that their respiratory status is going to improve because we've removed that fluid or we removed that air. But if there's a problem, that you're not going to see that respiratory improvement, and it's going to get worse. So that's a big indication to you that there's a problem, right? Thoracentesis should relieve that issue, and it's not. If that's the case, we're going to get that chest x-ray or CT so we can confirm whether or not there's a pneumothorax. Again, if we have a chest tube, we're going to check that dressing site, right? If their respiratory status should be improving, not worsening. If that dressing is not occlusive, remember we said it closes that site off, keeps it free from infection and air going into that pleural cavity, we have a problem, right? So we're going to check that dressing too. And the assessment, as we discussed above, right? We're going to be doing all of that respiratory distress assessment and looking for those signs of good perfusion. And then, again, we have to intervene rapidly. This is an airway breathing circulation problem for sure. When we're talking about fluid displacement, it's not just happening in the lungs, it can happen in the abdominal cavity, so ascites can be a problem. And again, that's just fluid accumulating in a space where it's not supposed to be. It's uncomfortable, not usually painful. It's that very bloated, distended feeling. And we treat this with paracentesis. So in the similar way, we do thoracentesis up in the pleural space to get rid of that fluid or air. We have paracentesis to relieve the pressure in the abdomen. Problems with ascites, it can slow down that peristalsis. Obviously, that feeling of fullness, bloating, or distension can interfere with appetite. Can also affect the body's ability to expand the lungs down as we breathe in and breathe out. When we do paracentesis on these patients, we want to make sure that they're in the high Fowler's position, right? Because what you want to see here is you want to see that fluid draining down into the abdominal cavity. We insert that drain, and of course we get out all the fluid that we can. We talked about oncological emergencies in our general cancer overview, and I told you that we'd be relating them to specific cancers. And so in this case, this SIADH, that syndrome of inappropriate diuretic hormone, that is our cancer emergency. Where we're going to see this is with our lung cancer patients, and the most common cause is that small cell lung cancer. It is a fluid balance problem. So we have uncontrolled water reabsorption, but we also have hyponatremia, right? So we're excreting that sodium in the urine and our sodium is dropping, which if you're not aware of it by now, that can be a real significant problem. And it has to be handled delicately. So what that means is we're going to transfer this patient to the ICU. They are absolutely fluid restricted, right? We already have a water problem and we have a diluted sodium concentration. We're not going to throw more water at the problem. They are going to get a slow and concentrated sodium replacement, and they're going to have to be monitored very, very closely as as sodium levels are restored. Again, it's taken very slowly. We can't raise those levels quickly. It's why we can't do this on the floor. They need the type of management that we cannot provide to them on the floor. So we know that we're going to have low sodium levels, right? We're going to be retaining fluid, and ultimately this can cause this renal failure in the patient, okay? So it is an emergency. It has to be addressed quickly. It has to be addressed delicately and in a very controlled environment, which is why these patients head to ICU. We're not going to give them fluid by mouth. We're going to restrict that. We don't want to compound the problem as we're trying to resolve it. And so, yeah, serious complication of lung cancer.